Sorry, Bruce, but I have a question.
Yes.
Can a person change one man's life? The answer is yes for me. You have changed my life and probably the lives of many others around the world. Bruce Miller is my mentor and close friend for 19 years now. And he's a person that inspired me and others to our work, never denied his support, and a friend who has been by our side all these years. I will never forget our conversations, joking around Golden Gate Park or strolling in Greek islands. This is for my friend and my mentor. Of course, Bruce Miller is also an exceptional physician. He has received many awards, including the Potemkin Award from American Academy of Neurology, the Elliot Roger Award from San Francisco Neurological Community, the Robert Fishman Award and Lecture. Now I'm reading UCSF Lifetime Achievement in Mentoring Award, and of course he's an elected member of the National Academy in Medicine. He holds the A.W. and Mary Margaret Closen Distinguished Professorship in Neurology at San Francisco, and he's the director of Memory and Aging Center and co-director of the Global Brain Health Institute. He's a behavioral neurologist. He was interested and studied extensively neurodegeneration and especially frontotemporal dementia. And it is used as a window, I think, to study the underpinnings of human behavior and creativity. Bruce has pioneered changes in the provision of care coordination for patients with dementia and their caregivers. GBHI is a major training program for global leaders around the world to reduce the scale and impact of dementia. I think Bruce Miller is the right person to tell us the future of neurodegeneration upcoming years. Bruce, please.
John, thank you. Magda, thank you for this wonderful opportunity to speak to one of the most vital programs in the world on neurodegenerative diseases, to think about the future. I'm going to say a word about the past from me. So it was 50 years ago in the summer that my wife and I first visited Greece. We fell in love with the food. We fell in love with the people. We fell in love with the islands. And still, this is a country that is so dear to my heart. And 19 years ago, another very important thing happened to me, and that was meeting John Papantriafoulou. And what an incredible friendship we have had over the years. Magda, I admire so much what you have done. John, I admire so much what you have done. There's a new generation of Stelios Zagouras who has worked with us at UCSF, and I hope that many more people from Greece will continue this friendship between UCSF and the Mediterranean region. So I'm going to give a sweeping talk. I will stay within my time limit. I'm going to talk about early Alzheimer's disease, frontotemporal dementia, and dementia with Lewy bodies, with one central theme, and that is that proteins spread in a very specific circuitry, and that spread of proteins determines the clinical phenotype. So I think the more deeply we understand the first manifestations of these diseases, the more deeply we understand human behavior, and the more likely we are to find a treatment. I will touch on next a little bit about the new biomarkers for Alzheimer's disease and amyloid lowering therapies. This is the future. This is what we will have by 2020, 2030. Great biomarkers and clinical trials that will lead to better therapies. Next, I will talk about frontotemporal dementia. Again, where the molecules begin to cause havoc in the brain, how they spread. And I think my talk is in honor of John and Magda, both psychiatrists. And I will emphasize that all of these diseases begin with a psychiatric prodrome. And the last few slides, I will talk about what I've learned about how our society should care for people with the degenerative disease. And then 4 points about the future of degenerative diseases. So here are the proteins. Alzheimer's disease has different proteins than frontotemporal dementia, than PSP, then the synucleinopathies, and of course, Creutzfeldt-Jakob disease. 1982, Stan Prusner at UCSF made the revolutionary idea that these bad proteins spread from one cell to the next in what we would call a prion-like fashion. These are, from my point of view, all diseases that spread via the misfolding of proteins that go from one cell to the next. So I'm not going to emphasize this. I think the Mediterranean is probably the place that we've learned the most about Alzheimer's disease prevention. It is your wonderful diet, your vigor and physical activity, your prevention of cardiovascular risk factors, the fine Greek education, the focus on good treatment of depression, preventing smoking, having better sleep. These are all risk factors for dementia. And we think by 2030, and there's already evidence for this in high-income countries, if we approach these risk factors, society will have 40% less dementia. What an extraordinary idea. And I think, again, this comes out of the Mediterranean region. We need to live in a way that we protect our brains. This is not only true of Alzheimer's, it's also true for the other degenerative diseases. Okay, here is I think maybe my summary slide about how these diseases present. Fact and fiction. Degenerative disorders begin with changes in cognition or movement. Wrong. Most start with a psychiatric prodrome that is key to early intervention. Psychiatric symptoms lack science relevance to dementia. Absolutely wrong. These psychiatric symptoms are key to understanding the major features of all of the degenerative diseases. Another myth, mood, anxiety, and withdrawal are a reaction to the illness. Sometimes that's true, but often these are the changes in the basal ganglia, brainstem, and frontoinsular region, depending on your disease, that are causing the psychiatric symptoms. The mood and anxiety is the beginning of dementia with Lewy body. The social withdrawal is often the beginning of FTD or Alzheimer's disease. So I think if we don't focus on these symptoms in later life, we will miss all of the earlier stages of these diseases. And then I think in dementia, we have given the psychiatry community an incredible roadmap for understanding mood, emotion, psychosis, compulsions, because we see these symptoms in degenerative diseases and understand the exact circuitry that drives these different psychiatric symptoms. So I think this will lead to much better insights into primary psychiatric disorders. Here are some of the psychiatric syndromes that I think often precede one of these degenerative diseases. Many of these psychiatric syndromes I've written here occur before someone is diagnosed with frontotemporal dementia, but depression, anxiety, social withdrawal, these are often features of Alzheimer's or dementia with Lewy bodies. So late life psychiatric symptoms, almost always the harbinger of a degenerative disease. Okay, how do we differentiate these diseases? I think the spirits, the Greek gods, have made this relatively easy for us. It has allowed us to, because of the different anatomy of these diseases and the different molecules, to differentiate AD from FTD, from the Parkinsonian dementias and DLB. We all do this in our clinics, and we now do it with great precision. Alzheimer's, memory disorder, sometimes begins in the cortex with spatial problems or word finding difficulties. The MRI is fairly characteristic: medial temporal lobe atrophy, diffuse atrophy, biparietal temporal atrophy. This is the Alzheimer pattern. PET, we see amyloid positivity and tau positivity in the Alzheimer pattern. This is what Alzheimer's disease is. And I'll touch on, we now have great biomarkers in the blood that I am sure will be, with all of us, cheap, inexpensive, as a way to capturing where amyloid and tau is in the brain. Frontotemporal dementia, behavior, 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 sometimes starts with executive disorder. The symptoms are due to injury in the frontal, anterior temporal lobes, also the thalamus and basal ganglia. PET, not yet friendly to the diagnosis. FTD is amyloid negative, so we rule out Alzheimer's disease. The tau ligands we have are not yet specific enough, but they are coming. And I hope in 3 or 4 years, we will have very specific tau ligands for the tau types of FTD and TDP43 ligands for the TDP types. Neurofilament, I'll touch on, becoming a very powerful biomarker for FTD. And 15% of these cases have autosomal dominant genetic cause. John, Socrates, Gersa Viener in the Mediterranean have all done exquisite work to capture the genetics of the Greek and Turkish population with FTD. Parkinson's disease, complex, starts with movement, sleep, mood, and autonomic dysfunction. The MRI is less focal, less diffuse, less hippocampal atrophy. Sometimes it is predominantly posterior. We have no PET, no blood biomarkers for the Parkinson's dementias. They're coming, but the only thing that we have is the Alzheimer biomarkers when there is dual pathology, which there often is. I think early features of these diseases are even more interesting. The work that I'll touch on suggests that Alzheimer's disease, even before there is memory difficulty, there is neuroticism, hyperemotionality, social withdrawal. The changes in motion are normal, no movement disorder. Although I will say, and this is work that comes out of the Mediterranean region, we know that essential tremor is a risk factor for Alzheimer's disease. Personality in the prodromal phases, normal, neurotic, or introverted. Cognitive, we have different subtypes with a prodrome. So we now know if you were dyslexic, and you get Alzheimer's disease, you often develop a language variant described by Marilu Gorno-Tempini, LVPPA. If you have math or spatial deficits as a young person, it seems to predispose you to the posterior cortical atrophy form of Alzheimer's disease. Risk factors for Alzheimer's disease, sometimes the beginning of the disease, I think, is sleep apnea, poor sleep, and certainly if you have been given benzodiazepines or other medicines that prevent you from getting into deep sleep and clearing bad proteins, this is a risk factor for Alzheimer's disease. FTD, I'll talk more about this in a minute, the emotional changes. Most patients are motorically normal, sometimes tremor or axial rigidity, or ALS is the prodrome related to motion. Personality, every subtype just about, because I think almost every subtype of personality is driven by frontal, temporal, subcortical circuitry. Prodrome, I think we have written about visual creativity, certainly in the progressive aphasias, that emerges as a prodromal feature of progressive non-fluent aphasia and semantic variant. Finally, DLB, I see this again and again. Before someone develops problems with movement, before someone develops hallucinations, they develop an unexpected anxiety disorder or depression, often years before the onset of their illness. One of our own faculty from the Mediterranean region, Andrea Saratin, a psychiatrist, has demonstrated this definitively in our Parkinson's population. High incidence of anxiety disorders, depression later in life. Motion, I think macrographia, tremor often precedes the full-blown PD, DLB syndrome. There's literature on excessive conscientiousness in people who develop Parkinson's disease. And I think I will just say sleep, we all know. REM behavior disorder, 60% of our people with DLB, PDD, and this is a group of people in whom poor sleep can sometimes be the first manifestation of the illness. This is just one example of the work Virginia Sturm is doing at UCSF. She has shown increased neuroticism, smaller social networks in people who are amyloid positive, but cognitively negative. The smaller social networks in the people who are not yet showing evidence of memory disorder correlate very strongly with decreased connectivity in this posterior cingulate region. So the smaller social networks driven by very specific focal dysfunction, a prodrome of Alzheimer's disease. AD, I think many of you have seen this slide. The pathophysiology starts 20 years before we get sick. Beginnings of amyloid protein aggregation. We can see this with PET, now with blood biomarkers. About 10 years before the onset of symptoms, we see tau visible with tau PET. Neurodegenerative disease changes like atrophy start to occur 5 to 10 years before the onset of the illness. MCI, then a formal dementia. This gives us a huge runway to begin thinking about preventative therapies, whether it's Mediterranean diet or an amyloid lowering protein. I'm a Taoist. I truly believe that tau is the best target for Alzheimer's disease. This is a nice slide from Leah Grinberg lab. It shows the slow progression of tauopathy beginning in the brainstem, spreading out into the hippocampal and entorhinal region, transentorhinal, and then finally full-blown cortical involvement. Where tau is where we see symptoms. Leah has taught me, don't forget the brainstem as a possible cause for early manifestations of Alzheimer's disease. Very, very important work. All right, why is tau so important? Because baseline tau predicts future brain atrophy. This is a nice paper from Renaud Lajoie from our group. He looked at 32 patients with MCI, Alzheimer's disease, dementia, looked at A beta with PET, tau, evidence of neurodegeneration with 3T MRI, and then followed 15 to 18 months later, and then looked at the MRI. What is the punchline? Where tau was is where we begin to see atrophy and neurodegeneration on the MRI. Okay, I'm a Taoist. Let me say a little bit about the Ni Aaa Research Framework. This was devised by radiologists. It has its pluses, its minuses, but I think this is a step forward toward 2030 when we have biomarkers as a way to be sure that our clinical diagnosis is right. So here is the Atn Biomarker Grouping. A is the aggregated A beta. T is the aggregated tau or neurofibrillary tangle. And N is the neurodegeneration or neuronal injury shown by MRI, FDG PET, or CSF total tau. So if you are A negative, T negative, neurodegeneration at negative, you do not have Alzheimer's disease. If you are amyloid positive but T negative, you are beginning to show the Alzheimer's pathologic change. If you are A and T positive but still don't show atrophy, I think this is unusual, by the way. We are comfortable calling you Alzheimer's disease. The full-blown Alzheimer's disease often has all three, A positive, T positive, imaging evidence for atrophy. This shows you here some patients, I'll show you an example, who are amyloid positive but T negative, but show really gross neurodegeneration, probably have non-Alzheimer's pathologic change and concomitant early Alzheimer's disease. By 2030, this is the way I think we will be thinking about many of our patients. An example, thanks to Gil Rabinowitz. So this is a 75-year-old individual with multi-domain dementia. We see this all the time. The amyloid is diffuse. In no way does where amyloid deposit in the brain reflect the dementia syndrome. This person, though, has tau in the posterior parietal region, temporal region, and neurodegenerative changes suggesting atrophy. So this is a classic Alzheimer's disease. We see this every day in our clinics. Here's a 91-year-old individual with a severe amnestic dementia. Remind you, amnesia has got a differential diagnosis. This 91-year-old has amyloid throughout the brain, but there's no tau. Unusual for a 91-year-old, but no tau. And lots of evidence for anterior temporal atrophy. So this has got the beginnings of Alzheimer's disease with the amyloid, but also very strongly suspected non-Alzheimer's disease pathology. So with just these two biomarkers, A beta PET, tau PET, we are really getting good at knowing what is Alzheimer's versus a non-Alzheimer's dementia. Spinal fluid biomarkers of A beta, tau, and neurodegeneration are with us. This is AD 2021, and we know AD has its own specific signature. Look to 2030 for other blood and CSF biomarkers that tell us whether there is axonal degeneration, neurofilament, What is the density of our synapses? Is there synaptic dysfunction? Is there inflammation? So stay tuned for even more incredible biomarkers over the next decade. New York Times, amazing, isn't it? Long sought blood test for Alzheimer's in reach. I'm proud to say that some of this work comes out of the Memory and Aging Center led by Atn Biomarker. In this case, the New York Times is right. Blood tests are coming. This is two different, very powerful studies, one Schindler, one Thiessen, but senior author Atn Biomarker. Basically, it tells us that our blood biomarkers for tau almost completely correlate with a tau PET scan. So I think we now, and the same is true for plasma A beta, have blood biomarkers that will be used extensively across the world. Even low-income communities, I think, will be able to afford this to tell us whether or not someone has Alzheimer's disease, the A and the T part of this. Gil Rabinowitz has done a huge study in the United States thinking about just amyloid scanning and its value to 18,000 clinicians, 18,000 cases with MCI or of dementia of uncertain cause. The hypothesis of this study was that in diagnostically uncertain cases, amyloid PET will lead to significant changes in patient management that will translate into improved medical outcomes. I think the story is true. I urge you to read this really nice paper by Gil and Jama. But these clinicians, once they had the amyloid PET, changed management, changed counseling, changed diagnosis in at least 25% of the people that they saw. So amyloid PET is expensive, but stay tuned. We are going to be able to do this with blood. Okay, PET is already being used as a primary outcome measure in clinical trials. You can enroll patients pre-PET, determine what the amyloid status is of the patient, and then determine if the drug is engaging the target. This is a study written in Nature, prematurely, I'm afraid, that showed that aducanumab with an anti-amyloid antibody actually was clearing at least one form of A beta from the brain and the blood vessels. They have done further work in this space, have gone to the FDA for approval. The FDA, and I think with good reason, although I think there were some reasons that this might have been approved, has held off approving because the clinical outcome was not nearly as impressive as the amyloid imaging. So aducanumab certainly reduces amyloid by PET. This is the EMERGE and ENGAGE studies. The clinical data is a little less impressive. I think we will hear Biogen present this again in March to the FDA. And I really don't know what the FDA was going to decide. Nobody does, but it'll be a very interesting day for our field. Okay, well, this just summarizes what's happened so far. The FDA said there were alternate explanations for the apparent drug benefits in the post-hoc subgroups. They were post-hoc subgroups. Biomarker data were consistent with target engagement. There was some evidence with CSF, phosphorylated tau, that we may be affecting neurodegeneration. But they're still certainly on the fence about this. Won't go into this very much, but we now have donanemab, another amyloid targeted antibody. I think the clinical data and the PET data are more impressive, but I will also say this is a very small study, and we will certainly need a bigger study to know whether we will have antibodies or other amyloid lowering therapies for us by 2030. I also say stay tuned for tau lowering studies. I think these may be very powerful. Okay, amyloid tau have transformed Alzheimer's research. They allow detection of pathology, follow the evolution of Alzheimer's in living people, major impact on clinical trials and drug development, probably a huge impact on diagnosis and care. Blood tests will take biomarkers to the next level, easier access, lower cost, probably a gateway for future scans for FTD and DLB. You knew you weren't going to hear me without me talking about frontotemporal dementia. So this is the clinical syndrome of FTD. For psychiatrists, this is all psychiatric. Disinhibition, apathy, loss of empathy, compulsive behaviors, overeating, executive dysfunction, all driven by the frontotemporal atrophy, the neurodegeneration, in a different region than Alzheimer's disease. Just like Alzheimer's disease, the Braak staging, we also have BV FTD MRI atrophy staging. Glenna Holliday in Australia really pioneered these staging efforts. It begins in the frontoinsular region, spreads out into dorsolateral prefrontal cortex, and my fellows and young faculty at UCSF have also taught us that while the frontal lobes are being affected, so are the thalamus and basal ganglia. So this is a frontal subcortical neurodegenerative disease. Very focal, even in the end stages of the illness, the back of the brain is usually spared. This is Bill Seeley's, I think, pioneering effort. What Bill showed here is that in patients in the very earliest stage of frontotemporal dementia, just beginning to show functional impairment, the first neuron that is affected is this phylogenetically new neuron, the von Economo neuron, in which TDP-43 has left the nucleus. It is now no longer regulating more than 100 proteins, either up or down regulating them, becomes abnormal and spreads out into the cytoplasm. This is FTD central, where the first neuron affected in frontotemporal dementia. How do we protect these neurons? I think that is the key to prevention of FTD. This is a nice work done by Alyssa Nanali, which took people in the earliest stages of frontotemporal dementia and again showed that the abnormal TDP-43 was first evident in the von Economo neuron and the related fork cell, where there is no longer TDP-43 in the nucleus. Again, Don Cleveland has shown that this changes either up or down regulation of more than 100 proteins. So you could not see something more devastating to a cell than the loss of a nuclear protein that is critical for the modulation of different proteins. Okay. Same thing happens if you have frontotemporal dementia due to a tauopathy. And this is, again, a very nice paper out of the Seeley lab, L.C. Lin, Alyssa, Bill Seeley. And again, it shows the first stages of frontotemporal dementia due to tau, Pick's disease, cortical basal degeneration is abnormal tau in these von Economo neurons. Okay, this is what Bill Seeley calls ground zero for frontotemporal dementia. One of the key findings of the last decade is the discovery by Mark Diamond in Dallas that in cell culture, you can watch the spread of abnormal tau, misfolded tau, from one cell to another. You can see here all of these cells where misfolded tau is spreading and causing a very severe neurodegenerative phenotype. If we can prevent the spread of tau from one neuron to the next, we believe that we will prevent neurodegeneration. We can visualize this now in some tauopathies, in PSP, for example. This is a nice study by Raquel Gardner. Raquel showed that there was hypoconnectivity in what she called the PSP network, dentate nucleus of the cerebellum, thalamus, basal ganglia, and then a disconnection of prefrontal cortex. With the tau PET, you can see the tau is exactly lodged within the regions of this connectivity map that is leading to the disconnection. So this is, I think, a powerful example of how tau spreads in one neurodegenerative disease. By 2030, we will be able to stop that spread and hopefully even prevent it. I'm not going to talk about Lewy body very much. It's not my area of specialty, but I will just point out, number one, these research criteria are insufficient because I think so many people with DLB in the prodromal phase have depression and anxiety. I think we have to do better in terms of our diagnosis. But I think what this emphasizes is what the alpha-synuclein does in the brainstem in sleep centers, leading to REM behavior disorder, in the regions of the brainstem that alert the cortex, causes changes in cognition, visual hallucinations, and in the midbrain causes Parkinsonism. It's all anatomy, where. Here is our hypothesis. Early changes in the brainstem reticular core, Braak stages 1 to 3, devastate serotonergic, noradrenergic, cholinergic systems in that brainstem core. Therefore, the first symptoms of this disorder are often sleep or anxiety or depression. Fascinating illness. So much helps us to understand manifestations of psychiatric disorders. Frontotemporal dementia, an early age of onset disorder. We were told in the last decades, don't pick Pick's disease or frontotemporal dementia. You couldn't diagnose it. It's rare. Nothing could be farther from the truth. It's a major cause for dementia under 60. If we include ALS, which is often linked to FTD, PSP, cortical basal degeneration, CTE, we have a very common cause for neurodegenerative disease. Also, there are many FTD changes later in life that reflect this neurodegenerative process and often co-occur in the setting of Alzheimer's disease. So always think Pick's disease, whether young onset or AD later in life, because you'll often see FTD proteins. 3 variants, I won't go into this, but isn't this amazing that where the brain degenerates determines what molecule we can predict? 2 aphasias, 1 semantic variant, 85% of the time TDP type C. Non-fluent progressive aphasia, almost always cortical basal degeneration, Pick's disease, PSP. When not, I would say the 10% of the remaining 15% are caused by a progranulin mutation. So we are getting very good by the phenotype at predicting the underlying molecular pathology. FTD, just like Alzheimer's disease, I think one of the real advances in FTD, and we're now studying large cohorts, is that we start to see neurofilament rise, probably in the early some people call it mild behavioral impairment phase of frontotemporal dementia. So this is going to be, I think, a really powerful biomarker for knowing when that slope is beginning to change. So all of the clinical trials that are coming look to this neurofilament as a biomarker of axonal degeneration. Here are the different diseases of frontotemporal dementia: 3 tauopathies, 3 TDPopathies, 1 very related disorder caused by a protein like TDP, FUS, happens in young people. And here is the dipeptide repeat that is characteristic of TDPB associated with the C9orf72 mutation. Chronic traumatic encephalopathy is a tauopathy and a TDPopathy. So I think this behavioral psychiatric disturbance in the prodrome is really part of the broad umbrella of the frontotemporal dementias. 3 main genetic mutations. I'm not going to belabor this point, but I just want to comment that we can't treat FTD as one entity. And I believe that's true of Alzheimer's disease as well. I think very, very badly mistaken to believe that if you're 60 with Alzheimer's or 95, that amyloid lowering will be highly effective. I think we really have to target different clinical molecular subtypes for all of these diseases if we're going to have therapies by 2030. So the tau mutations, a lot of them in Greece and in Italy, we know this. The therapy is clear. If we can lower tau in the nucleus, the production of tau, or increase its degradation in the lysosome or proteasome, we will have a powerful prevention for tau mutations. Look for studies using CRISPR, antisense oligonucleotides. This is going to be the decade of tau, and I think by 2030, the preventions will be with us. Progranulin, totally different mechanism, similar phenotype, but this is due to too little progranulin in the brain. I've heard of 4 different companies all approaching ways to raise progranulin in the cortex of these gene carriers. I think, again, if we can do this, this will prevent the neurodegeneration caused by too little progranulin in the brain. The problem now is we do not have enough worldwide progranulin carriers for all the brilliant scientists ready to treat this. So this is a plea for, and I'd love to work with you in the Mediterranean region to have a network of gene carriers that we can, I think, lead the way in therapies for the frontotemporal dementia. C9orf72, again, a different mechanism, but clearly, if we can turn off that bad gene, we will have a powerful prevention for the major genetic cause of frontotemporal dementia, the major genetic cause of ALS. Stay tuned, these studies are just starting. Familial Ftd, this was a conference we put on in 2012. I point out that across Asia, almost no genetic mutations. It's at the time in South America, almost no genetic mutations. Thanks to Gursev, John, others, we are starting to see lots of mutation carriers in Greece and other parts of the Mediterranean. So I think one of the things that I think is critical if we're going to do these clinical trials is to have more people who have familial frontotemporal dementia. Here's the major US network led by Adam Boxer, Brad Bove, Howie Rosen, sites across North America collecting genetic and sporadic cases. Europe led by John Rohrer, we have GenFree. I'm really proud about this next network led by Augustin Ibanez, connected to GBHI, but we are now adding many FTD patients from Brazil, Ni Aaa, Colombia, Ecuador, Argentina, Chile. This is a huge initiative that I think will make prevention possible. Let's have a Mediterranean NIH-supported initiative for FTD. There are early imaging biomarkers in these gene carriers before someone shows atrophy, at least with progranulin. Susie Lee has shown that there's hyperconnectivity in different networks depending on the phenotype that you're about to develop. Sharon Shaw has shown massive atrophy. This is faster, more malignant than Alzheimer's disease in progranulin carriers. In this study, by 8 weeks, she was showing when people became symptomatic with progranulin, marked loss of tissue. Neurofilament, look at how exciting this is. Normal people, non-carriers, low levels, begin to show axonal injury and C9, progranulin. You're starting to see elevated neurofilament. By the full time the dementia is present, axons are leaking neurofilament. Great biomarker. It will be used in our clinical trials. And I think clinicians will use this as by 2030 as you think about your patients. Where neurofilament is rising, we will see, just like tau aggregation in PET and Alzheimer's, a decline in the next year. Okay, just a few words about the psychiatry of frontotemporal dementia. It starts in the medial orbital frontal cortex, in von Economo neurons. It affects addiction, rewards. This is work by Kringelbach and Rolls that shows that you have abnormal reward mechanisms if you injure this part of the brain. What do we see in our patients? Addiction, disinhibition, all driven by the anatomy of FTD. Isn't that amazing as a finding to think about general psychiatric disorders? Brief image of a patient who is addictive, he's overeating, he's disinhibited, and he's got repetitive compulsion, requires him to give people back rubs.
We never go the first Sunday of the month because that's communion. In our communion, you walk down front, and as you walk down the aisle, everyone was greeted and back rubbed and asked where they were from, which is very disruptive.
Doesn't know this gentleman.
Africa.
He's given everyone in our program a compulsion, but certainly disruptive disinhibition. These women don't like this very much, as you can tell. This is where behavior in FTD meets society. Nowhere are we required to be more socially correct than our houses of worship or in funerals. And this is where FTD people show wild disinhibition. Crime is an early manifestation of FTD. Behavioral variant, almost 40% in this study. This has been borne out across many nations. Crime is an early feature of FTD. Loss of empathy, this is work Kate Rankin has done. How important is this for society to understand the circuitry of empathy? People who lack empathy cause as much damage in our societies as is possible. We had a leader in the United States who lacked empathy. He didn't have FTD, but we can imagine that dysfunction in this empathy circuit was a major, powerful impact across the world. Again, I mentioned early, and I'm coming toward the end of my talk, lifestyle can alter cognitive trajectory, not only in Alzheimer's disease, but even in genetic forms of frontotemporal dementia. Great study by Caitlin Casaletto. Does lifestyle matter in genetic FTD? She had 105 mutation carriers. They were CDR0 or asymptomatic at baseline. The deterioration in these two groups was very different based on physical activity and cognitive activity. So if you're a CDR of 0 and you are physically active and cognitively active, you show a much slower conversion to formal frontotemporal dementia. Still questions about chicken and egg with this study, but I think in a year or two, we'll have thousands of gene carriers and we'll really be able to test this in a very powerful, formal way. So I believe even if you carry a gene for a disease, the lifestyle that you live is very important. We have therapies around speech, and I think never neglect rehabilitation in early Alzheimer's disease, DLB, the non-fluent aphasias. We can make an impact on these people. We can make an increase in the quality of life based on treating symptoms that they have. As the disease progresses, not so powerful. But this is the beginning of a society thinking about how to intervene in people who are developing illness. Empathy, I've learned a lot about caregivers from Alzheimer's disease. A nice paper by Akitoshi Takeda, marital dissolution infidelity, greater in BVFTD than any other dementia, empathy loss associated with marital dissolution. And if you were a BVFTD patient whose marriage had dissolved or experienced infidelity, you showed lower empathy scores. So this is putting huge burden on caregivers, this loss of empathy, this lack of caring for someone you love. This is FTD. This is the burden for patients and society. We've learned that where degeneration happens in a patient's brain influences caregiver psychopathology and caregiver global health. It is the most burdensome of all degenerative diseases because the frontal lobes are what connect us to people that we love. Coming next, better diagnosis, new causal genes, big grants. Let's get one in the Mediterranean region, better therapies for the molecular forms of these diseases. 2030, let's have this disease beaten. Let's stop the scourge of this horrible degenerative illness. Two last slides. Society is going to have to think about people afflicted by this. Have a system that helps caregivers. We have shown, this is Kate Posine's work, that if you have a caregiver navigator who interacts with the patient and their loved one and helps them to navigate social systems, you improve quality of life, you reduce emergency visits, and you decrease caregiver depression and burden. All societies need help for people with chronic illnesses, but even more important than the person, I think it is the family that supports these people. We are using this now across the United States. It's cheaper than not intervening, much more humane, thanks to Kate Posine. Okay. Dementia 2030. Society is organized to prevent dementia. It's a lifelong effort. You may be the first society in the Mediterranean to do this well. You care about each other. Preclinical diagnosis is possible. Screening for everyone over 40, maybe even earlier. Prevention based on molecule-based interventions. Care systems to support the patient and the society. One last comment. I hope many of you will come to the International Frontotemporal Dementia meeting that is happening March 3rd through 5th. Look at UCSF CME to sign up for this conference. It's 3 days. It's going to be a powerhouse. I hope all of you will join. Thank you for this opportunity.
Thank you, Bruce. Thank you very much. I don't know, Magda, do we have it's very, very nice, very astonishing.
If there are any questions, we have 5 minutes not to tire more Professor Bruce. If there are 1 or 2 questions, I think that you will be willing to answer them.
Great.
So, is there any question? Are there any questions? I would like to ask you a question. There is an opinion in the United States that monomers, amyloid beta, and plaques, and are not the target of the medication that we have prepared, and perhaps the toxic oligomers are the right target. And there are now two medications which are on phase 3 clinical trials, BAN 2401 and ALZ 801, which have as target toxic oligomers amyloid beta. What is your opinion about this?
Yeah, I think, you know, we can never abandon the amyloid hypothesis of Alzheimer's disease, because we know if you have a mutation that leads to increased amyloid, you will get Alzheimer's disease. The problem, I think, and I learned this very early in a vaccination study done by Athena Neuroscience. So what they did is they vaccinated against A beta, powerfully effective in clearing A beta from the brain in people with Alzheimer's disease. Really nice work done by the Swiss that showed that in people in whom the amyloid was cleared, there was still a relentless progression of the neurodegeneration with tauopathy. So I think after that study, I began to believe that even clearing A beta in the very earliest stages was not going to be enough, that we would need dual therapy, that we would have to not only affect A beta, but we would also have to treat tau as well. And I think universally, we've been disappointed by the data with the amyloid clearing drugs, particularly as the disease advances. And that's because I think, and Stan Prusner has shown this in animal models, that there are two preanopathies going on. One is amyloid, one is tau. And we have to treat both, I think, if we're going to have efficacy. So I don't think the amyloid alone will be highly effective. I'm not even sure it'll be effective at all, but I think there's a glimmer of hope now. So I think we will know in 2 years, if these studies are all negative, we're going to have to move to something different.
Thank you very much.
Bruce, there's also another question from Ms. Katakalu. Was the man in the video aware of the changes of his behavior? Was he happy? He was talking to people. Was he enjoying the process of communicating this way?
Yes, it's a great question. So I think loss of insight is almost invariable with frontotemporal dementia. The progressive aphasias, no, they know. Alzheimer's 50-50, but FTD, no insight, zero insight. And lots of euphoria. I think I always stress to the family, the person who is suffering is them. It's not often the person with FTD. So carefree, happy, no concerns. I think that is what happens when you injure the anterior cingulate cortex.
Thank you. There is also another question from Socrates Papageorgiou. Although preventive strategies seem to be effective for AD, what do you think for other degenerative dementias?
I'm a believer in exercise. I think there's new data on exerkines. These are molecules that are released when we run, when we do different forms of exercise. These are good for the brain. They're good for our psychiatric status. I think they're preventive. I think even in the genetic forms of FTD, that exercise is probably preventive. So I think the things that, you pioneered in the Mediterranean, Nicholas Skarmeas with the diet, all of you, different forms of this, I think really important. I think it doesn't matter what disease. I think all of these degenerative diseases can, to some degree, be prevented by lifestyle.
Is exercise a medicine?
It's a medicine. It's my favorite medicine. John, if I had to spend a Saturday and Sunday when I didn't run, I would be miserable. I recently, with one of our Pilates teacher, we did a joint talk, and there are two different circuits in the brain that we activate. With running, for me, it's in the quiet of Golden Gate Park. My default mode network is active. I'm in pleasurable thinking about all of the different issues in my life. When I do Pilates, it's the salience network. I'm highly focused on my abdomen, my core. So I think different forms of exercise give us a double hit of medicine.
Thank you, Bruce. Thank you very much. Magda?
I would like also to thank Bruce for this excellent presentation, and I would like to say goodbye to everybody. About 200 people, 200 scientists had the opportunity to hear you, Bruce, in Greece. I think that they will not forget this evening because it was very, very amazing. Thank you very much.
Thank you very much.
Magda and John, I never would have guessed when I was hitchhiking in Europe in 1971 that I would have an opportunity to speak to this illustrious group of people in Greece.
And
so
I think you wanted to go to Eos and you went to Chios.
Yes. We didn't speak good Greek. So when we asked the ferry driver, we want to go to Eos, they gave us a ticket to Chios, but it was glorious. It was wonderful.
Okay.
Thank you, Bruce. Thank you. Thank you. Bye.
Thank
Bye.
you. Καληνύχτα σε όλους.
Καληνύχτα, καληνύχτα.